I have been a speech pathologist for the past 16 years. I've kind of done the gamut in pediatrics. I started as a school-based SLP, working only with preschool populations with special needs. From there, I moved down to early intervention programs, got bored with that after a few years, took a job as a traveling speech pathologist and only had a caseload of kids with high needs related to autism, and then ultimately came back, did a little bit of home health work. At some point during that time went, I can do this. If my home health company is doing this, I can do this, and kind of took a leap of faith that I could start my own private practice. And we're in year 9 now, approaching year 10. It's kind of been a roller coaster, but I wouldn't change that roller coaster for anything. So I do that. I am Vice President for Social and Governmental Policy for our state association, which is Texas. That in and of itself is a roller coaster. I spend about 20 to 40% of my week in Austin at our Capitol, giving policy briefings to senators, our representatives. I sit in meetings with our Health and Human Services Commission, and I get down to the nitty-gritty of actually writing our speech therapy policies for our Medicaid and CHIP population. More recently, we have battled the state over provider reimbursement rates. So I've gotten down to the nitty-gritty of billing methodology, codes, you name it, and really have gone to battle with them over what they're going to have to pay providers in our state so that our providers will actually service that population of our patients. So I do a lot of that. Probably, I think I'm on year 5, maybe year 6. ASHA has, for their Medicaid, their Medicare, and their school-based populations, they have state advocates, and they have one advocate that represents each state. So within Texas, I'm the star, and we love that title because we're stars, but it's essentially the state advocate for reimbursement, which means I serve as the liaison between ASHA and my state association on everything that is reimbursement-related, policy-related, for Medicaid and CHIP reimbursement, as well as for commercial reimbursement. And beyond that, avid football fan. When I was first asked to present this weekend, the first thing my husband looked at me and said was, "What's the football schedule?" and it is an away game. We're playing Ole Miss after I finish presenting today, so he's already got his eyes on where we're gonna watch the game tonight. So that's a little bit about me. Financial disclosures, your state association has paid my travel expenses for me to present today. So that's our financial relationship. And now the framework for today's presentation. We're going to spend the first half on coding principles and the second half of this presentation on ICD-10. Throughout today, I want this to be interactive. My experience when I go to presentations like this is complex, hard information that nobody finds particularly enjoyable. It's compliance. And sadly, there's not a lot of ways to make this fun. But when I leave these presentations, be it at an ASHA conference or the Business Institute, I usually feel 2 things. A, there were 80 slides in this presentation, and we only made it through 40 or 45 of them because people in the audience had so many questions. And B, I leave going, great, that's a lot of information, but I don't necessarily know that I can do it yet. So I want 2 things today. I want you guys to stop me, ask me questions, let's have conversations, and B, as we go through this, we're going to do live demonstrations. We're going to go over, I have links through this presentation as we go today. We're going to live link over to those websites, and I'm going to show you how to do this. We're going to practice how to do this, because when you leave this room, I want you to feel confident that you can do this. So I don't have 80 slides today. I have closer to 50 slides, and it is my goal to get through all of those slides and answer every question that you guys have along the way. So when you have a question, stop me, interject, let's tackle it together. A few things. None of this information is necessarily information that I have created from scratch. ICD-10 coding principles are ICD-10 coding principles. Those are established at the federal level. What I generally consider myself good at is I am a good culler of information. I know how to compile information, and I know how to find information. So I'm not necessarily reinventing the wheel here. We're going to use a ton of ASHA resources this morning. What I am not is an audiologist. Do we have any audiologists in the room? Okay, so we have a couple of audiologists in the room. So I have included information for audiologists this morning. So we're going to cover the speech portion of it. We're also going to cover the audiology portion of it. And to put this presentation together, I actually had to learn the audiology portion of it, which was great because it forced me to find information, synthesize it, and put it all together. And that is literally what I'm hoping that you guys are going to be able to leave here today and be able to do. So we're going to interject a little bit of humor, although there's not a lot of humor to be interjected. ICD-10 is officially here, and it's been coming for years. Many thought it wasn't actually going to happen this time, but it has in fact happened. If you know even a little bit about ICD-10, you know that we have tens of thousands of codes now, and some of those codes are absolutely absurd. You think, how in the world could that actually be a code? These are not actually codes. Interestingly enough, my husband is an IT guy, so he helps me put all of this to paper and formulate it. And I was like, David, we need to find the ICD-10 codes for Star Wars. So I Google it and I pull it up, and he starts reading them and he goes, wait a minute, are these actually codes? And I'm thinking to myself, love, you know me enough to know that Star Wars codes can't possibly be codes. But nonetheless, he actually Google searches to see if these Star Wars codes are real codes. No, they're not. But he reads this page of nothing but Star Wars codes that somebody has fictitiously created. And he jokes with me, the person that creates these doesn't even know Star Wars. That can't even possibly happen. So he's not satisfied with the codes that somebody else has fictitiously created for Star Wars. So he has come up with his own set of codes. So these are compliments of him. The first, and he says bonus points to anybody that can get this, U1138.00A. Frozen in carbonite, still not thawed, initial encounter. Anybody? That one is Han Solo. Han Solo. The next one, a little more straightforward. U1138.00C, Stormtrooper Rash, initial encounter. He was okay with that one. He didn't change it. But U327.028, speaks words out of order, initial encounter. Yoda. And he was very determined he was going to make a speech pathology reference, and he's like, what's the diagnosis for that? What is it? What is it? And so he was determined. And then the last one, U327.11D, arm removed by Chewbacca, initial encounter. So a little humor to start the day. Some of them we're actually going to get to later in the deck. They're literally that absurd, although they're not Star Wars based. And you honestly think to yourselves, how in the world did somebody ever come up with this? But a little bit of humor. So we have, in terms of healthcare coding systems, we have three major sets of codes that we use as healthcare professionals. We have our CPT codes, which are our current procedural terminology codes, and those describe what we do with the patient. So for example, 92507 is a CPT code. That is a code for speech therapy. We are providing speech therapy. That is a CPT code. And then we have our healthcare common procedures coding systems, our HCPCS codes. And those are the supplies, equipment, and devices that we use to perform the therapy services that we are providing. And then our third set of codes are our International Classification of Disease codes. And those describe why we are treating the patient. Those are our now ICD-10 codes. So we have what we're doing, what we needed to do it, and why we are doing it. We have 3 sets of codes that we use. Why do we code? Coding provides a common language for us to use as providers, for insurance companies to use, and even for benefits administrators to use. It is a common language that everybody can understand across all healthcare settings. Coding allows us to standardize reporting procedures, and that has become a big deal with the passage of the Affordable Care Act. What they found prior to its passage and in the years leading up to it was everybody was coding in various ways, and there was no uniformity. And so what I might code as one thing, somebody else would code as something else, and a third person was coding as something else. So it really standardizes the process. And now more than ever, CMS, our Medicaid insurers, our commercial insurers, they're really starting to narrow in on coding. And that's becoming a big deal, and correct coding is becoming a very big deal. Coding provides data, and this is why it's becoming a big deal and why there's a focus on correct coding. It allows our insurance companies to evaluate our quality. And as we move to new payment for performance systems, there's an emphasis on value and quality. Are the interventions that we are providing high quality services? So in other words, there's maybe 20 or 30 of us in the room. We are all being measured against one another. Over time, insurance companies intend to look at their provider contracts and only keep the providers in their networks that are providing the highest quality interventions at the best value. And so it becomes a very big deal if you are a provider, especially if you are a provider that is out in a solo practice where you are doing your own coding and billing, or you work in a hospital system and your hospital is competing against a second hospital to show that the services you provide add value and are of high quality. Because long-term, what we're being told is they intend to terminate provider contracts of those providers that have the lowest quality services. And I don't know about y'all, but that's a little bit frightening. That's a new way to think about how we deliver services. It used to be, I delivered a service, I got paid for that service. I delivered a service, I get paid for that service. That's that fee-for-service model. And that model is going away, and we're shifting to alternative payment models where quality is item number 1. A second thing that coding provides is utilization patterns. They're going in to determine, based upon a procedure code and a diagnosis code, what's the average number of sessions it is actually taking our providers to treat a patient from start to discharge. And is that 10 treatments? Is that 20 treatments? Is that 50 treatments? And they're hoping to identify some utilization patterns that they can use to better determine annual benefits. And we should expect to see moving forward that if you're treating a speech and language patient who is a 4-year-old child with an articulation delay, the average number of sessions it takes from start to finish is 40, for example. And they intend to begin to limit the number of sessions provided to what those average utilization patterns are. So they are calling information for utilization patterns. We're not there yet, but we do believe that that's where they intend to go. A third is to look at healthcare costs. That is a big one. Healthcare spending is outpacing inflation by there's a substantial difference in healthcare costs versus inflation costs. So what's the average cost to provide this service? Fee schedules. That's another big one. We are using the data collected to help determine fee schedules, and lastly, to compile basic health statistics, which maybe in terms of what matters to us on a day-to-day basis doesn't seem to be as big a deal, but for the CDC, those healthcare statistics are a very big deal. So any questions on that? Okay. Now, coding principles. Our CPT codes are copyrighted by the American Medical Association, and they are updated annually. Probably the biggest change we've seen to the speech therapy codes in the last few years is regarding our evaluation codes. 92506 used to be the standard evaluation code that we used for speech and language evaluation. Now we have 92521, 92523, 92522, 92524, and 92525 even. So we've broken that out. Voice, fluency, articulation only, articulation, and language. And now there are very specific guidelines on which sets of those codes you can bill on the same day of service and which you can't. They did that because they felt like 92506 was too broad a code. We were billing 92506 at a payment rate that generally sat up here, yet we weren't necessarily doing every possible evaluation we could do when we first evaluated a patient. So CMS and the American Medical Association thought to themselves, let's break this down into the components that 92506 actually represented, and let's pay for each individual component based on the procedures that were done. And so all of our new evaluation codes for speech and language delays actually tend to pay at a lower reimbursement rate than 92506 once paid. So they are updated annually. CPT codes describe how to report procedures. Every medical, surgical, and diagnostic procedure is assigned a 5-digit code. 92507, 92526, 92523, they are all 5-digit codes. There are limitations on the use of those codes. We have the National Correct Coding Initiatives, which are the NCCI edits. Others call them the CCI edits. We have the medically unlikely edits, and we also have the outpatient code editors, and we're going to talk about each of those in more detail. So, for a speech-language pathologist, most of our CPT codes are event codes or procedure-based codes. The code is reported one time regardless of the length of the intervention provided. So 92507 is an example of a procedure code. According to correct coding guidelines, we report 92507 one time a day, whether that therapy session was 30 minutes in length, 45 minutes in length, or an hour and 15 minutes in length. The way it is intended to be billed is as a procedure code. Speech pathologists do have a few codes that are not actually procedure codes and are instead time-based codes. Those include our speech generating device evaluation for the first hour, and then each additional 30 minutes for a speech generating device evaluation. Our aphasia evaluation is coded per hour. Our oral rehabilitation evaluation, first hour, and then each additional 15 minutes of the evaluation receives another code. So we do have a few instances where it varies procedure versus timed code, but not too many. So the NCCI edits. The edits were developed by the Centers for Medicare and Medicaid Services, and they're updated quarterly. The edits are used to determine which CPT codes can be paired together on the same date of service. So it's a guideline for billing. The goal of the edits is to eliminate mutually exclusive code pairings and codes to be considered components of more comprehensive services. The best example I can give of this is the code for an articulation evaluation and the code for articulation and language evaluation. So we have articulation evaluation only, which is 92522, may not be billed on the same date of service as the code for an articulation and language evaluation, which is 92523. And they can't be billed on the same date of service because 92522 is a component of 92523. So the edits are designed to catch those types of overlaps. Another example that ASHA provides, a provider may not bill procedure code 92607, which is the speech generating device evaluation, on the same date of service as 92597, which is the voice prosthetic evaluation. Those are considered, and that's considered an overlap of the codes. Now, when do you use the edits? The edits are used when you're reporting Medicare Part B claims. According to the Patient Protection and Affordable Care Act of 2010, state Medicaid programs should also be using the NCCI edits. Most commercial insurers also follow the edits. There are instances when insurers don't follow the edits. There are instances when Medicaid agencies don't follow the edits. The key here is to know your payer source. And if they are telling you to do and to follow a billing methodology that is contrary to the NCCI edits, the best piece of advice anybody can give to you is get it in writing. If they expect you to bill in a manner that does not follow the NCCI edits, they are certainly welcome to do so, but you protect yourself most as a provider if you have that in writing. That actually occurs within the state of Texas. Our commercial insurers follow the NCCI edits. Certainly Medicare, for Medicare Part B claims, are expecting providers to follow the NCCI edits, but our state Medicaid agency is not asking us to follow the NCCI edits. In fact, they're asking us to treat 92507 as a time-based code. So we are billing that code in 15-minute increments. I saw you cringe. We cringe as well because although a few years ago that didn't seem like a big deal, it has now become a big deal because our state wants to know why they have spent so much money on speech therapy services for kids enrolled in the Medicaid and CHIP program. They did so because they allowed 92507 to be billed in 15-minute increments up to an hour of treatment a day. They valued the code substantially higher than what 92507 is valued at as a procedure-based code in any other part of the country. Fortunately, they had put it in writing, so we all had it in writing, so we could all look at the payer source, which was our state Medicaid agency, and say, this is happening because you instructed us to do that. And so it is a very hard argument for them to come back to us now and say, you overused the system, you engaged in wasteful practice, because we can counter and say, we only followed the instructions that we were given. But we had that in writing. The danger is if you do not have it in writing. Staff at insurance companies change frequently. I'm not going to say it changes as much as staff turnover occurs within our field, but staff turnover occurs. So it's not sufficient if 3 years down the road you are audited and somebody at the insurance company says to you, why did you bill that way? Well, Sally Jane in a phone conversation a few years ago told me to do it that way. if Sally Jane no longer works at the insurance company and it was a verbal conversation only, you as a provider have no protection. So be sure to get it in writing because it is the greatest form of protection that you can have. Any questions about that? Okay. Now, the outpatient code editors. The OCEs only apply to hospital outpatient services. They're very similar to the NCCI edits, and they are updated quarterly as well, 1 quarter after the NCCI edits are updated. Generally speaking, whatever the NCCI edits will say, the OCE edits will say as well. So here is an example of what the NCCI edit table looks like. And we're actually going to live link over. This comes directly from an ASHA webpage. So if all goes like it should right here, we're going to live link over. And we're going to be able to pull up ASHA's guidelines for the use of the NCCI edits as well as the outpatient code edits. And this is where I love ASHA. It makes my blood boil sometimes when I hear people say, ASHA doesn't do anything for us. What has ASHA done for me lately? ASHA does so much for us, and I am not a paid ASHA employee, so there is no financial plug here. But ASHA does so much for us, and the membership dues we pay to them are worth every penny we pay. Because when I talk to my OT friends and I talk to my PT friends, their national office doesn't come close to producing this type of content for them. But this is an example of the CCI edits page. It will give you your table lists. So it will say that code pairs that cannot be billed together by one provider for the same patient on the same date of service. And then as we go through, it has this exhaustive list. So if you want to know what 92507 can and cannot be billed with on the same date of service, it will tell you right on the chart. If you want to know what 92522 may or may not be billed with on the same date of service, it will tell you right there. So when in doubt, if you ever have a question and you're doing your coding and you want to think to yourself, may I bill this on the same date of service? Here's where you go to find that information.
And for those of us who don't routinely code, is there an index that tells you what all those refer to?
There is. We're going to, as we continue to go through here, I am going to show you exactly where you find a description of every single procedure code, the whole 9 yards. But this is where you're going to go for your NCCI edits. I'm going to minimize here. Okay. Now we have our medically unlikely edits. Our medically unlikely edits are the MUEs for any given code determines the maximum number of times per day that the code can be reported on the same patient. So if you want to know how many times can I use 92526 or 92507 in one day, this is the place you go to find that information. They are also used when reporting Medicare Part B claims. They should also be used by your Medicaid payer sources. So if you have Medicaid managed care organizations here within the state, they should be used by them. They should also be used by your commercial insurers. Again, know your payer source. If your payer source says no, you can bill 92507 twice on the same date of service, and you have that in writing, and it is medically appropriate to do so, then you can bill 92507 more than one time on the same date of service. The key is to know your payer source. So here is an example of the medically unlikely edits chart that ASHA provides. We'll live link over to that as well, so it's nice and big. It gives you a description from ASHA of exactly what the medically unlikely edits are, what their purpose is, and then it will tell you for every procedure code the number of times you can bill it within the same day. So you have a medically unlikely edit for the office setting as well as for the hospital outpatient setting. Any questions about that? Yes, ma'am.
Occasionally in our clinic, we work with children who are also receiving services through the public school,
Yes.
and they do bill Medicaid
Mhm.
in New Mexico. If we bill Medicaid and they bill Medicaid, how does this scenario work out?
That is a state-specific issue. North Carolina, for example, and I don't want to state this wrong, but I believe in North Carolina, you get a maximum number of speech therapy sessions for the month, be that through the school program or through the private provider. They can be billed on the same date of service, provided the total number of services delivered doesn't exceed the allowable for the month. In other states say if it is billed through the school district, it may not be billed through a private provider at all. You have another group of states that says if it's billed through the school district, it may not be billed on the same date of service as the private provider. And then you have a fourth set of states like Texas who says, we don't care. We have a provision for services through the public school system. We have a provision of services through the Medicaid payer source. Those services are separate from one another, and if they're billed on the same date of service, they're billed on the same date of service. If they're not, they're not. So that's definitely an instance in which you have to know your payer source. You should be, does New Mexico have Medicaid managed care? Or are you guys all on fee-for-service? A mix? Okay, so really you have to go payer source by payer source by payer source. Fortunately in Texas, our state Medicaid agency has said they're two distinct places of service. You can bill them on the same day. But that is an exact example of when you have to know your payer source. So my recommendation would be to go back to your Medicaid contractor and say, may I bill speech therapy services on the same day that they are provided within the school district. Does that answer your question? Okay, awesome. Okay. Whoa, that's not the one I want. Okay. Here are several resources for speech-language pathologists when you're thinking about using procedure codes. We have our reimbursement and coding guidelines, which talks to you more about CPT codes. It gives you a model bill for speech-language pathology services. It provides you ASHA's Medicare fee schedule for the year. It gives you information about coding by topic. It gives you more information about the use of timed versus untimed codes. It talks about case management services. It talks about Medicare-specific coding rules for speech pathology services, and it also talks about same-day billing procedures. So here's an excellent resource on reimbursement using CPT codes in general. Yes, ma'am?
Is this totally up to date?
This is completely up to date as of last week. So, as of last week, yes, ma'am. Okay. Okay, we're gonna have to go back one. Let's go to the second one. Now, here is more coding information by topic. We have coding information for oral rehabilitation, for electrical stimulation, for augmentative communication. You have your Medicare CPT codes, your National Correct Coding Initiative guidelines, and even just frequently asked questions. So here's another excellent resources to go to. You have information on co-treatment, evaluation, medical team conferences. You name it, as a general rule of thumb, ASHA's probably got it. And the great thing if they don't have it, and we're going to get to that resource later, is they have a team dedicated just to answering our questions. All you have to do is send them an email and they will respond back to you by that email. If you ask them a question that is state specific and they're not sure of the answer, they will reach out to their state advocate. If it's a Medicare issue, they'll reach out to their Medicare representative. If it's a Medicaid or commercial insurance issue and it's state specific, they'll reach out to that person. They are extremely responsive as they go through. And then the last one is another link to the edits. Come on. Okay, or not. Okay, now for audiologists, and I promised I would not forget y'all. We also have resources for audiologists. For our audiologists, they have Common Healthcare Economics Committee answers to what are supposed to be your most frequently asked questions. And so you can go through and it'll give a question and answer for all of that. And then audiologists also have their own set of NCCI edits, as well as their outpatient code editors. And so as you go down through here, it will take all of the most commonly used audiology codes, and it will begin to tell you what you may and may not bill on the same date of service. Okay, now, modifiers. And modifiers are being used more and more on insurance claim forms. So I have our GN modifier. Is everybody familiar with the GN modifier? Ish? Okay. The GN modifier is essentially used to indicate on a claim form that they were speech pathology services. If you're looking at a line on a claim form, there's a spot for the date of service, a spot for the procedure code, a spot for the modifier. At this stage of the game, almost all of our insurance companies, Medicare Part B, our commercial insurers, and our Medicaid payer sources are making us report the modifier GN on our claim forms. There's also a modifier to indicate that it's a PT service. There's a modifier to indicate that it is an OT service. So that's the modifier that just basically says this service was performed by a speech pathologist. We don't have too many codes that overlap with OT and PT. It becomes a bigger deal for OT and PT because they have one specific code that they both tend to use a lot. And there are limits to the number of times per day that that particular code can be used, whether it's performed by a PT or an OT. And so for them, it's really important that they have that modifier on there because it distinguishes, was that procedure code done by the OT, was that same procedure code done by the PT? But nonetheless, that modifier should be on all of our claims at this point. Now, we have the modifier 22. That is our modifier to indicate that a procedure took substantially longer than you expected it to take. The American Medical Association, in conjunction with CMS, has established an average amount of time it should take to perform every procedure code. Some payer sources, and again, this is payer source specific, will actually reimburse you higher than the allowable amount when the procedure code takes substantially longer than you expected. So if the general conventional amount of time is 2 hours, but for some specific reason it took you 3.5 hours to complete this procedure, that would be the instance in which you would use that modifier 22. A payer source may or may not pay that. You definitely have to know your payer source. The key here is to not overuse it. This should be used in an exceptional circumstance. If you begin to put this modifier on every one of your claims for every one of your patients, at some point your payer source is going to ask you, why is everything you're doing taking twice as long as your colleague at the facility 10 miles from you? You're going to catch their attention, And you generally don't necessarily want to catch their attention because that may mean you are visited with an audit. So if you use it appropriately and use it sparingly. Now, modifier 52. That code should be used if it is an abbreviated procedure. Did you do less than expected? The most common instance at this point in time is probably with code 92523, which is our language and articulation evaluation code. In principle, if you only evaluate a child's language function, an adult's language function, and you do not assess their speech production, you should use that modifier 52. Using that modifier 52, depending upon your payer source, may mean you actually get reimbursed less than the allowable for procedure code 92523. That is payer source specific. My payer sources within the state of Texas for my pediatric populations, they don't have a way to even handle the modifier 52. So we got in writing from them, what's your expectation regarding the use of that modifier? We, clear as day, don't use it. So we know that we are okay not to use it. When you're talking about 92523, how many times do you actually do a language-only assessment? Almost never.
With an adult, though, if you're doing an adult eval,
Mm-hmm.
like in a nursing home setting, you really are looking at language, like in its abbreviated time as well.
Mm-hmm. That would be the instance in which you would put that modifier.
Or what if you did speech and language, but it was abbreviated time?
I'm sorry?
If you did assess, so then in that same situation, if you did assess speech and language, but it was abbreviated time, would you still use that, or is it truly just if you only evaluate one?
It's truly if you only evaluate the language. So the guidance I have heard from ASHA representatives is, somebody in the room said almost never. You are making in an assessment a judgment about their speech production, correct? Comment on that. Although a formal pronunciation assessment or articulation assessment was not administered, dynamic assessment throughout the session revealed the following. Comment on it. If you've commented on it, that should be sufficient. So that's the best recommendation that we can give. If the primary emphasis with 92523 is language only, be sure to comment on the speech pronunciation aspect of that particular patient. If there are no findings to report, your finding is simply their speech production is as expected for the patient's age, ability levels, etc. Any questions about that? Yes, ma'am.
I do have a question on your site. Where you put it does evaluate sound production.
Sorry, okay. So should be used with an abbreviated procedure. The modifier 52 should be used with the procedure code 92523. It should say if the evaluator does not. I will correct that for you guys. Thank you. Thanks for the catch. So that should say does not. Okay. Other modifiers. Modifier 59, and this modifier is short-lived, but it's not been removed yet. So I'm going to cover it. Modifier 59 is used to establish one procedure code as distinct from another procedure code when billed on the same date of service by the same provider. That modifier is undergoing revision because the Centers for Medicare and Medicaid Services feels it is being overused. So, change is coming. It has hit our colleagues in other professional settings already. It has not necessarily hit us yet, but ASHA does have a couple of great resources up on that already. So let me just click you I didn't want to go backwards. Okay. Use of the same day billing coding modifiers. Let me get down to 59 here. Go through all of those. Are we up at the top? Code modifiers, there we go. GN. You know what, that one's not going as fast. Let me get us to our other one. Here we go. Okay, so here's a specific article that ASHA wrote at the end of 2014, and we can see here where they're going. They're going to a modifier XE, separate encounter, XS, separate structure, XP, separate practitioner, and XU, unusual, non-overlapping service. So they are in place, but speech pathology providers are not yet required to use them. So if you are billing Medicare Part B claims and you tend to use the 59 modifier, this would be a big article and a useful article to go back and review to get more information on the use of the replacement modifiers for modifier 59. So just be aware that if you're using modifier 59, changes are coming. They just have not hit us yet. Now, G codes. Familiarity with G codes in the room? Okay, I see some head nods. G codes are codes that I am less familiar with because I spend my time with the pediatric population. My general understanding is G codes are not fun, but G codes are a fact of life. CMS requires that providers report non-payable G codes for Part B Medicare beneficiaries. You have to use your G code in unison with a severity and complexity modifier. The G code must be included for every evaluation and every 10th treatment session. So we'll take a look at our G codes here. If we look at G codes, ASHA has them broken down. We have G codes for swallowing, G codes for motor speech, G codes for spoken language comprehension, language expression, attention, memory, voice, and other SLP functional limitations. So every 10th session and every evaluation, you should be coding the G code. If you fail to report the G code, there are financial penalties that you incur as a provider, and we're going to touch on those more in detail in just a couple of minutes. So know your G codes, have your G code list printed as a reference, but know that you have to report those G codes. They are not optional. In addition to the G code, you have to report your severity modifiers. There are 7 severity modifiers ranging from 1 to 7. CN is 100% impaired, limited, or restricted, and you would code that as a 1. CH is 0% impaired, limited, or restricted, and you would report that as a 7. So that severity modifier should combine with your G code and be included on your claim form every 10 sessions. Okay, I've pulled for you just a couple of examples of G codes for, this one's for swallowing, for example, as well as the link to it. And then here are your G codes for, actually we went one slide too far, spoken language comprehension, spoken language expression, and then there are your modifiers for your severity indicators. Now, local coverage determinations. Those are specific to the region of the country that you live in. So your local coverage determination as it relates to Medicare may differ from mine in Texas and will certainly differ from somebody's local coverage determination in Florida, in Maine, in California. The LCDs are coverage guidelines created by your local Medicare administrative contractor. They're created by your MAC. They provide rules for determination of coverage in the absence of a national policy. So if CMS does not have a policy, your local administrator has the ability to create a policy. When a national policy is unclear, your local coverage determination provides clarification. You need to know your LCDs. Again, I am not a Medicare coding expert by any stretch of the imagination, but I wanted to include it because I know that most people here in the room work with a broad spectrum of patients. You guys are a much smaller state. You are much more likely to cover the pediatric spectrum all the way to the upper end of the spectrum, whereas in our state, we have enough patients that we tend to have the ability to only treat peds, only treat adults, and do a little bit more specialization. It is my understanding that the LCDs do vary substantially. We have an LCD in our state, and I forget which specific code it is. It is a speech pathology code, but they will absolutely not cover that code because they consider it a psych code. So our SMAC, who is the Medicare advocate between ASHA and our state association, has done a tremendous amount of advocacy to try and get that policy changed with the local Medicare administrator. So follow your LCDs closely. ASHA does have a link that actually will take you to a web page that will help you determine who your local coverage determination and your Medicare administrator is. So if you're not already using the LCDs, use those. Now, shifting gears a little bit, we've got PQRS, which is our Physician Quality Reporting System. CMS designed the PQRS to improve the quality of care, there's that word, quality of care, that Medicare beneficiaries receive. PQRS is designed to track practice patterns, how much intervention is any one provider giving to any one patient based upon their diagnosis and severity as compared to a counterpart in a nearby community, a hospital setting versus an outpatient setting, a private practice versus an outpatient setting. As a result of the passage of the ACA, provider participation in the PQRS program is mandatory. This is data tracking. This goes back to those earlier slides. Why are we moving to ICD-10? Better reporting. The good news, because there are financial penalties associated with PQRS as well, it starts over from year to year. So if you come up short in 1 year and you incur financial penalties as a result, the following year you have an opportunity to right the ship and get back on track so that any financial penalty you incur doesn't sustain over the long term. So I've mentioned that failure to participate results in a financial penalty, and here it is. Providers that failed to report PQRS quality codes for more than 50% of their patients in 2014 will be assessed a 2% penalty on all claims in 2016. So if you did not do this in 2014, beginning in 2016, you will be subject to a 2% penalty for your Medicare claims. 2% doesn't seem like a lot, but 2% is a lot if you think about the total number of interventions you deliver in a calendar year. It adds up. I did include a source for that, so if you guys wanted more information from ASHA, this is the page that will take you. Again, it's healthcare reform driven, regardless of our feelings about healthcare reform, and that tends to be a fairly polarizing topic. At least for the foreseeable future, healthcare reform is here to stay. So these are things we need to embrace regardless of our feelings about them. But it will break down and give you more information. Okay. Now, PQRS, they have a source for audiologists. They also have a source for speech-language pathologists. So you can go discipline-specific here, and if you're an audiologist, you can pull up the PQRS reporting guidelines for audiologists. You can also do the same for speech-language pathologists. Now, value-based payment modifiers. We were, in addition to PQRS, in addition to G-codes, in addition to the severity modifiers, we were also supposed to be reporting value-based payment modifiers. So again, we're following a trend here, right? More coding, more reporting, more data, payment penalties if we fail to complete these tasks. In this particular instance, our value-based payment modifiers have been suspended. So here is one area where you can take a deep breath, take a sigh of relief. These will not be in effect in 2016. Had they gone into effect, instead of being subject to the potential of 2% payment reductions, you would have been subject to up to 6% payment reductions. And if you didn't think you were going to miss 2%, you will probably definitely miss 6% payment reductions. And here's what that means. These have gone away, but a replacement system will come. You can almost bank on that. So you don't have to worry about these now, but something else will end up taking their place. Again, this one was in an ASHA leader. My husband didn't get quite that far and get that one taken out. Let's see if that loads. Okay. So, good news, Medicare payments will stabilize in 2016 based on the proposed fee schedules, but this particular article in the ASHA leader will tell you more about those value-based payments, what the fee changes were. It talks about potentially misvalued codes. It pulls in a little bit of audiology. Again, this is where those ASHA resources, does everybody in here get a copy of their leader? I'll admit, and this sounds horrible because I'm up here presenting, sometimes life feels so chaotic and so busy that my leader comes in of a pretty big stack of leaders piled up that I haven't necessarily looked through. If you do nothing else, skim them and find the things that are most important to your situation in your practice setting. Almost every ASHA leader, they have something about reimbursement and coding. So if you are honed in right now on reimbursement and coding, spend 5 minutes, and if nothing else, go to those articles and pull those out. If you're somebody that's focused more on treatment, go find those for yourself. I mean, it's gotten pretty thick over the years. It used to be a little smaller. It's a lot of reading now, and I'll admit I'm a little guilty, but I at least pay attention to the leader articles that most relate to reimbursement, since that's where I spend my time. Now, moving away from PQRS, we move to HCPCS codes. And those HCPCS codes were the codes for supplies and devices and equipment. There are 2 resources for those as well, one for speech pathologists and one for audiologists. I'm going to pull the audiologist one up here because I think the audiologist may tend to have a bit more equipment than the speech language pathologist in the room do. So again, coding and reimbursement, let me find the HICS picks. Where are the HICS picks? Of course, this is going to fail me right at the moment. Okay. It's on this page. HICS picks will be on this page. So you can follow to there. It will take you there. You can find your link. It definitely will be there. Okay. Physical medicine codes. Does anybody use these? I see a lot of nodding or a lot of I'm not really sure what those are. That's a good thing. Physical medicine codes are not actually codes that speech-language pathologists should report. We will occasionally hear of instances when I present even within my own state where somebody comes to me and says, I'm using the physical medicine codes and I'm getting paid and it's awesome. And we go, not so awesome, because we're not necessarily supposed to use those codes. So CMS has specifically stated that SLPs may not report procedure code 97110 therapeutic exercises or procedure code 97112 neuromuscular re-education. Those are not codes, according to CMS, that we should be reporting. Again, if you have a payer source that will allow that, make sure you have it in writing. We also look at 97532, cognitive therapy, and 97533, sensory integration. Again, that link will take you to the Medicare coding rules. Again, this is very specific. Know your payer source. There are differences between your Medicare payer sources, your Medicaid payer sources, and your commercial insurance payer sources. So if you have a payer source that is telling you something contrary to this, again, just make sure you have it in writing, because that's your greatest source of protection. Now, we're at ICD-10, and I haven't necessarily looked. How are we doing on time? We're about 10:25. Is the break set for 10:30? Is that correct? Do y'all want to go ahead and break here now? Ask any questions? Do y'all want to do questions, break, and then we'll come back and we'll start ICD-10? Okay. Who's got questions thus far? Nobody? Okay. Awesome. Well, let's break. I think we're set for about a 15-minute break. So let's break. If you have a question you didn't want to ask in the bigger group and you want to ask me, come up and ask me. I know that that first part is pretty weighty and not necessarily fun. We're going to make the transition now away from all of the coding stuff and really into ICD-10. Have I thoroughly terrified everybody at this point? I see a few heads shaking up and down. It is, when you first hear this, it can be pretty overwhelming. Just remember that there are resources to help you guys. And Ash is one of your best friends. The very last slides we're going to cover your state advocate for reimbursement on your commercial and your Medicaid stuff. We're going to cover your state advocate on the Medicare stuff. We're going to make sure that when you leave, you have resources to take with you. And it does get easier. I was terrified when I started this 5 or 6 years ago, and I got thrown in by default. I happened to go to a state association meeting, much like y'all's. I sat down at the wrong table, plain and simple. I sat down with a group of former ASHA presidents and former state association presidents, and little did I know what I was going to get myself into. And I just sort of got assigned some tasks and went, I don't know this. I don't know how to do this. Help, help. And little by little, I started to figure it out. And it took a while. It didn't happen overnight. Just know you have resources to help. So we're going out with the old, ICD-9. The rest of the world has been out with the old for at least several years. We have been slow to adopt change. I think we delayed ICD implementation at least 2 times, possibly 3 times. Last year it was coming, it was coming, it was coming, and at the very last minute we slammed on the brakes and everybody said, we're not ready, you can't do this yet. They thought it might happen this year, but lo and behold, ICD-10 is here. So we dropped ICD-9 because it was more than 30 years old. ICD-9 was running out of codes. There were something like 8,000 available codes in ICD-9, give or take a couple. ICD-9 also contained obsolete and outdated terms. I'm sure you can think in your own practices how the use of our terminology has changed in our patient reports through the years. ICD-9 wasn't keeping up, and so ICD-9 contains what we would now consider some very derogatory terms that we would never think about using to describe our patients in 2015. So we've gone out with the old, and as I promised, we're in with the new. We now have 60,000 plus codes, I think 68,000 to be exact, and there's a code for that. If you can think of it, there's a code. These we have not made up. These are actual codes. V97.33XD sucked into a jet engine subsequent encounter. These are apparently real codes. Okay, if I had been sucked into a jet engine one time, I would think I would have taken precautions to avoid it a second time. Apparently, these are real codes. Struck by a duck, subsequent encounter. Walked into lamppost, initial encounter. Maybe I can see that one if we're down on our phones, texting and walking, not paying much attention, or perhaps if we've been out on a Friday or a Saturday night and maybe haven't enjoyed ourselves a little too much. The point is, it has some of the most absurd things we could ever think of, but when you're going from 8,000 codes to 60,000 plus codes, somewhere physicians along the way said, but I once had a patient who, and knowing they needed a code for that, that's how some of these things in all likelihood developed. So it does get a little absurd. So actually, I have 160,000 codes, so apparently I was low in my estimate. ICD-10 codes allow for greater specificity. They're 3 to 7 alphanumeric characters. So they're longer, they're more specific, they provide greater detail, reducing the chance for error. ICD-10 also allows for better tracking of incidence and the prevalence of disease. That goes back to one of those original slides about general healthcare statistics. ICD-10 is letting them get to that better data. Now, what does ICD-10 mean? And unfortunately, some of these are very real. They're very real in my own practice. You may experience payment delays or denials, at least in these first few months. Has anybody seen that yet? Okay. That's a good thing. We are actually seeing that. I have one insurance company that has yet to pay a single claim for the month of October. Typically speaking, that insurance company, if we bill it 1 week, they pay it the next week. So we are now about to start our 3rd complete week of October, and they have yet to process a claim. If you're the person responsible for the financial management of your company and responsible for the cash flow, you need to be aware that that's a possibility. I'm a relatively small practice, even for my own practice. That reduction in cash flow, because they're not even processing ICD-10 claims yet, is already $10,000 for my practice alone. When you're a small practice, that's a lot of money. Denials. One of my insurance companies, knowing that I am an advocate, knowing that I have the resources to push a message out to every one of my state members quickly, called me on October 5th or 6th. We want to let you know that we are aware that every single claim submitted for October 1st and October 2nd has denied. We are calling you to let you know that our system does not work. We know that you will get messages from your members. Please let them know that we are aware of it and we are working to correct it. Here's our estimated date to have it corrected. So I had one insurance company that just wasn't processing claims at all. I had a second insurance company that was denying every single one of my claims. No, it's a possibility. If you're responsible for the day-to-day financial operations of your organization, no, you may expect payment delays. For the payment delays and denials that we have had, I do have other insurance companies where things are working exactly like they should have worked. So there is some hope out there. And the hope is your insurance company's got it right and it's working. But be aware there may be some glitches. Here's a big one, and this is an important one for the next 11 and a half months. CMS has granted us all a little bit of leeway when we select our ICD-10 code. We have to be in the family of codes until this time next year. And I'll give you an example. The F80 series is used to describe language delays. Phonological disorder is F80.0, F80.1 is expressive language disorder, F80.2 is receptive and expressive language disorder. If I inadvertently select F80.1 instead of F80.2 or vice versa for the next 11 and a half months until this time next year, CMS is going to allow a grace period, and they will not come back in and recoup because you inadvertently selected the wrong ICD-10 code. Hallelujah, that is a blessing because there are a lot of these codes. With that being said, what I cannot do is I cannot take a code that should have been used for a swallowing patient and tack it on to my language patient. I am not in the family of codes. So know that you have a little bit of grace and that there's a little bit of room to make some mistakes, but do not intentionally select codes that are so far off base that they would make anybody go, how in the world did you select that code? Coordination with your PCP. If you have outstanding authorizations on file that were submitted with ICD-9 codes, you do not have to obtain a new authorization with the ICD-10 code. Thankfully, that reduces the administrative paperwork associated with this change. What you do need to do is coordinate with your primary care physicians or the physician of record to make sure that you guys are on the same page about the ICD-10 codes. You don't want a situation to arise where they have selected one set of codes and think it's one thing and you think it's a completely different thing. So quick calls to the PCP office to say, you know, what are the ICD-10 codes that you're going to be using for this particular patient? Have you thought about those? Just to make sure that there's some coordination and collaboration with your PCP, the medical home, and yourself. Now, okay, we've covered the flexibility part, so we're good there. This is another leader article that talks about that flexibility, so if you want some more specific information about the next 12 months, that link will take you to the ASHA Leader article. Okay. This is a big one, and it wouldn't seem like it should be a big one, but it happens a lot. Your CPT code, those codes we covered in the first half of this presentation, need to match to the ICD-10 code that you select. That seems to be a common sense match, but it isn't always the case. And I've given an example. You shouldn't be coding F80.0, which is phonological disorder, with 92526, treatment of swallowing dysfunction and or oral function for feeding. Yet we do see that happen. I sit in a lot of meetings with insurance companies, usually either because I'm expressing concern about their policies and procedures and the roadblocks that they've created to obtain therapy services for our kids, or because they're noticing particular patterns that my therapy providers are doing and they want to know, why are your therapy providers always doing this, or why are they always doing that? And one of the things that they say is that they will uniformly have providers only choose one diagnosis code regardless of the CPT code that they match it with. We've got to make sure that the CPT code matches the ICD-10 code. So in this instance, F80.0, phonological disorder, should pair with 92507, which is the procedure code for speech therapy. That is a logical match. It makes sense. So just make sure that it makes sense. Another big one is that you always code to the highest specificity. And we're going to talk about that in a little bit, but you will see in the ICD-10 manual NOS, not otherwise specified. That is a non-specific code. You want to try to avoid the use of an NOS code because it basically means you're saying, for example, if you have a swallowing patient, well, I know they have a swallowing problem, but I really don't know what type of swallowing problem that they have. Generally speaking, you guys are going to know what type of swallowing problem they have, so you want to avoid the use of the NOS and get as specific as possible. Now, reporting of codes. This is conventional coding practice, but there is a but. Know your payer source, and if your payer source wants you to deviate from this, ask them to put it in writing. And I actually had this situation happen on Monday of this week, sitting in a meeting with an insurance company. General coding principle states your primary code is the reason for the visit, meaning why are they here to see you? So you are reporting on a claim form, first and foremost, the ICD-10 code that is specific to their visit with you. Is that the swallowing code? Is that the voice code, the fluency code, the articulation code, the language code? First and foremost, you are reporting that ICD-10 code. That is your primary code. Your secondary code is the medical diagnosis or the underlying medical condition. So, the secondary code is required when a patient presents with an underlying neurological or organically based speech, language, hearing, vestibular, or swallowing disorder. If you are coding a secondary code, you want to make sure the physician's office has provided you supporting documentation. I think this happens frequently with our kids that are on the autism spectrum. We have a child that comes into our offices. We can take a look at them and go, we really think that this child is on the autism spectrum. But I have nothing in my medical chart from the physician that would support that. So my first step is to call the PCP's office and ask them do you have any information in your medical chart about underlying medical conditions? And if the answer to that question is yes, you want that sent to your offices. If I can get that sent to my offices, it drastically changes how I code. In the absence of that documentation, I will code a primary code only. In all likelihood, I'm going to code, hopefully he's going to get them to turn that down. In all likelihood, I am only going to code F80.2, receptive and expressive language disorder. If I can determine that there is a social pragmatic concern, I could also pull that code, which is, yes ma'am?
Can you repeat that? I'm sorry, I think I lost you in that.
Sure. Here, what if I come closer, does that help? Correct. If I have no documentation in my medical chart, and I can get no documentation from my physician that supports a diagnosis of autism, I have a primary code only at this stage of the game. And my primary code needs to come from our developmental group of codes, the F series of codes. So in that case, F80.2, and we're going to cover these codes. Don't worry about the specificity. I'm just trying to give an example now. But F80.2, receptive and expressive language disorder. If I've determined that there's a social pragmatic language disorder, there's also an F code for that. I could code that as well. If I can get that documentation from the physician saying, yes, this patient has autism, that completely changes how I assign my codes. Now, my primary code comes from the R series, R48.8, symbolic dysfunction. And the moment I code R48.8, which is a code for an organic-based speech and language disorder, I must report a secondary code. In this case, my secondary code, because I have documentation from the physician, becomes autism F84.0. So that is conventional coding, and we're going to go through these codes forwards and backwards here in just a bit. So don't worry. The key here is no. Primary code is what you are personally treating. The secondary code is the underlying medical condition. You should be getting these codes in collaboration with your physician so that the codes in the physician's chart matches the codes in your chart. They should match, and they should match that previous slide. They need to make sense. I had an instance this week. I was meeting with the chief medical officer of a children's hospital in Texas. They have taken our ability away as speech-language pathologists to fill out the prior authorization request form. And the expectation is the physician should fill out that form, submit for prior authorization, and then the information will be sent to me. It didn't take me but 2 weeks to figure out our PCPs did not understand ICD-10 coding, and they were pulling codes from I don't even know where, and they were not the right code. So I quickly called the insurance company and asked them, what is your expectation? And they were like, I just don't understand what the big deal is. And I was like, it's a big deal, because ultimately you have to submit a claim form with a CPT code and a diagnosis code, and those have to match your medical records. If they pull up your treatment note or your progress note and they see you've written this, but you've coded this, if you're audited down the road, you're probably not in a good spot. So I had a meeting with them earlier this week, and I asked them, what is your expectation? Is your expectation that we code using the codes the PCP submitted to you, and that you have sent back to me, or is the expectation that I follow conventional coding practice? And it was really funny because I had the director of provider relations in the room and I had the chief medical officer. And the director of provider relations said, does it really matter as long as you have a code or it's in the realm of all available speech pathology codes? And the medical director's head spins around and goes, yes, it matters. And I said, great, are you going to give me something in writing then? And she said, no, because I expect you to follow conventional coding practices, which was great. But I forced their hand to change that policy because it didn't just protect me as a provider, it protected every one of our speech pathology providers within that particular region. So coding's a really big deal because with the passage of the Affordable Care Act, there's a provision in there that says all insurance companies are supposed to do an increasingly high number of records requests to make sure the diagnosis and the coding was done correctly. So know that those need to match. Know that if an insurance company wants you to do something different, that's perfectly fine as long as they will put it in writing for you. Protect yourselves. Best advice. And yeah, we don't have any music now. So, sequencing. There are codes that require specific sequencing based on additional notes listed in the ICD-10 code list. And all of this is coming directly from ASHA. I didn't invent the wheel on this. I'm not taking credit for this. This is ASHA-driven guidance right here. And we're going to get you the sources for all of this. The variations are clearly identified at the etiology ICD-10 code and the ICD-10 code that identifies the manifestation. And here's ASHA's example. If an SLP assigns a diagnosis of dysphagia from the R13.1 series, the accompanying code first note directs the SLP to first list a separate code in the I69 series. Conversely, the I69 series is accompanied by a use additional note instructing the SLP to identify the type of dysphagia in the R13.1 series. So the I69 series in this case, I believe, relates to cerebral vascular accidents, strokes. So if the dysphagia was caused by a stroke, it's clearly telling you you not only have to code the dysphagia, but you also have to code why they have the dysphagia. Conversely, if you went to that section of the manual, that section of the manual would tell you you have to code the type of dysphagia. So that's something that ICD-10 provides in greater detail that wasn't as specific in ICD-9. There are excludes one notations and excludes two notations, which we'll cover on the next slide. If you see an excludes one notation, it indicates that the codes excluded should never be used at the same time as the code above the excludes one notation. You will see an excludes one notation when two codes cannot co-occur, such as a congenital form of a condition versus the acquired form of the same condition. It's not possible to have both the congenital form and the acquired form. And so here is ASHA's example. H93.25, central auditory processing disorder, has an excludes one notification that prevents a provider from pairing that code with F80.2 mixed expressive receptive language disorder. So it's essentially telling us if we use H93.25, we cannot use F80.2. And so it will tell you that as you go through the book. If you see an excludes one, you can use this, but you can't use it with this. The opposite is true of an excludes to notation. And excludes to notation indicates that the code may be listed together because conditions can co-occur even if they're unrelated. So in this case, when the excludes to notation is present, the provider may use both the code and the excluded code together. And let's see if I included an example of that. I didn't, darn it. Darn. Okay, now, that not otherwise specified code. Basically, we're using the NOS code if there's insufficient information in the medical record to assign a more specific diagnosis. They're not always avoidable, but if you can avoid it, you want to be more specific than the NOS code. So that may, let's say you get a referral and it's to assess swallowing, and you know that the patient has had a stroke. You may want to go back to the referral source and ask them more information about the stroke. The same is true with cleft lip and palate. There's a multitude of potential diagnosis code for the type of cleft palate only, cleft palate with this, cleft palate without this. We have a cleft palate specialist in our practice, and oftentimes our scripts come across with patient has a cleft lip and palate. Treat, evaluate, and treat. I have to go back to the PCP, back to the referral source and say, can you give me more specific information? Because there are something like 10 or 12, maybe even more than that, that I could potentially include. If they don't have more than that, then I need to code the NOS because I don't have something more specific, but ideally I need to make the call back to the PCP to see if I can be more specific. Other codes, I don't know that we're going to use this one all that much, but it is there. There's sufficient information in the medical record, but no code exists for the specific condition. If you think back to that first slide where we're talking about like walking into lampposts, I can't imagine we're going to think of too many instances where we might need to use another code, but there is that possibility. Okay. What do you do if you get normal results? You get a request for a referral to evaluate and treat, but you evaluate and there's no reason to treat. How do you code it? If the results of a diagnostic assessment indicate normal findings, you code the symptoms that related to the referral. So whatever the reason for the referral was is what you code. Your clinical report should reflect the reason for the referral and the findings. No need for further treatment, patients functioning within expectations, within normal limits, whatever the phrase and terminology is that you use. But normal results code according to the diagnosis for which the patient was referred. Now, don't code just because you know the code will get paid. I hate to say that we've seen this, but unfortunately we see this. When you are a pediatric provider, it does not take you too long to figure out that insurance companies do not necessarily like our developmental codes, our habilitative codes, and they prefer our organically based codes. Unfortunately, we have had some providers that know if in the old language, if I used a 700 code instead of 300 codes, I could get my 700 codes through, but I couldn't get my 300 codes through. Now we're talking in ICD-10, in some instances, the difference between F codes and R codes. And I get emails about this. I wish I could tell you guys I don't, but I get emails. I can't get anything approved. What codes should I use? You can't pick a code just to get it paid or just to get services prior authorized. If you are doing that, if you know of somebody doing it, it is fraud, waste, and abuse any way you slice and dice it. And ignorance is not bliss. you are expected to at least have a foundational understanding of coding principles and practices. Don't code conditions that were previously treated and no longer exist. You code them for the time that they're a concern, and once they are not, they fall off, and you code the things that become a concern. Yes, ma'am?
We've had something come up similar to that. It was a language disorder as a result of a hearing loss.
Mm-hmm.
The hearing loss has been corrected.
Did.
Or it surgically, it no longer exists. But the language disorder that resulted from it persists. What about something like that?
I'm going to say I will tell you what I think the answer is, but I would say this is where you would want to go back to ASHA to be positive. I believe that for the time the hearing loss existed, you would code the language. I believe it's F80.5 language as a result of hearing loss. If the hearing loss has remediated itself, either because of surgical intervention, whatever the case may be, I believe we would flip back over to F80.2. But that is one that I would defer to ASHA. And this is my mantra. When in doubt, ask. I think I have a pretty firm understanding of it, but even when I am not sure, I go back to ASHA and I ask. I would rather be safe than sorry. So that is the same type of recommendation I would give you in this instance. To be safe rather than sorry, I would go back and ask ASHA. They have specialists that do nothing but this. Don't code suspected, questionable, or probable diagnoses. Best example I can give goes back to the autism one. We see it, we think it's there, we think there's a probability that it's there, but it hasn't been formally diagnosed, or we know it's there and it just hasn't been formally diagnosed. You can't code it. You need to get the documentation from the PCP. So if you see it, if you suspect it, but it's never been diagnosed, the best thing to do is recommend the referral back to the PCP. Say, hey, here's what I'm thinking. I really think that this patient would benefit from additional assessment to help us, determine the underlying cause of our speech and language delay. Once you get that additional information, if it changes the codes, then you can code it differently. But we shouldn't be coding things we suspect. Now, these are coding principles. We're going to cover some coding principles for audiology and then coding principles for our speech-language pathologists, again, coming from ASHA. So coding for central auditory processing disorder, the most appropriate code is H93.25 rather than F80.2, mixed receptive expressive language disorder. Coding for bilateral hearing loss, and this is per ASHA. Unilateral hearing loss codes that include unrestricted hearing on the contralateral side are creating a problem for coding different types of hearing loss in each ear. There is a proposal to the NCHS to address new codes for those times when there is restricted hearing loss on the contralateral side. So, when it happens, this is their recommendation as of right now. The only way to code two different hearing losses is to use the unspecified hearing loss codes, one for each ear, according to the type as follows. And then they will list H90.5, unspecified sensory neural hearing loss, H90.8, mixed conductive and sensory neural hearing loss, unspecified, or H90.2, conductive hearing loss, unspecified. There's a resource for that for the audiologist in the room. This is an example of where if I were an audiologist, I would want to monitor this fairly closely because ASHA is clearly advocating to the AMA and to CMS to get us some better guidance and some better codes so that you can be more specific when assigning ICD-10 codes. Because you know this, you'd want to be keeping a watchful eye out for communications to see, does this recommendation sustain long-term, or are there provisions put in place that allow us to be more specific? Now, you have coding for a failed newborn hearing screening. H91.90 is unspecified hearing loss, unspecified ear. You could also consider using a code in the H91.9 series. And when there's not enough information to assign a more specific diagnosis, use an unspecified code. This would be an example where you would use that NOS code, not otherwise specified. So there are instances where it's appropriate. There is a source, when you click to here, for frequently asked questions for audiologists. So if you're an audiologist, you have a question, I'm not sure what code to use, that's a good starting point because they've done a tremendous number of FAQs. Now, for speech language pathologists, these are groups of commonly occurring codes for us in ICD-10. F80.0, phonological disorder, that would have previously in all likelihood paired with 315.39 with ICD-10. F80.1 is now expressive language disorder. F80.2, mixed receptive expressive language disorder. F80.4, and I believe I told you F80.5 earlier, it's F80.4, speech and language development delay due to hearing loss. You also need to code the type of hearing loss. Requires a secondary code. And I'll admit, I had done these slides for a presentation 6 to 8 months ago, and I was doing my ICD-10 coding conversions not too long ago for my own practice. And then I went to work on these slides, and I went, oh, I don't think I coded this one particular child correctly. And I quickly went back and made sure that I got that secondary code in. F84.0 is autistic disorder. F84.5 is Asperger's syndrome. Some fairly commonly used codes that we're likely to see. Other commonly used codes are 47.89, which is other speech disturbances. We have an apraxia code this time, R48.2. And then R48.8, other symbolic dysfunctions, agraphia and echolalia. This is the code that if you have a kiddo with autism, that R48.8 would be the primary code. And this is ASHA's note. Organic-based speech, language, or swallowing problems, such as those related to cleft lip or cerebral palsy, are coded using the R series code. When you have an underlying medical condition that contributes to the speech and/or language deficit, the secondary code should be included on the claim. So this is that example of your primary code and your secondary code. If you're coding something in the R series, you should have a secondary code on your claim. As compared to your kids with more developmental needs, habilitative needs, who might only code using the F codes, which were on the previous slide, F80.0, F80.1, F80.2. Is everybody clear on that? No? Okay.
I'm confused on the F84 autistic disorder. When we use that versus the R.
Okay, so you would use them together. So your primary code is R48.8, other symbolic dysfunction. If they have a diagnosis of autism, your secondary code, the code you report second on the claim form, is the F84.0. They code together.
So if we see them it doesn't matter if we see them in the area of articulation, language, or both. If they have a diagnosis of autism, we do the primary R code, the secondary F84.5, and nothing else.
Yes. That is correct.
Same way with a child with CP.
So a child with CP, you might want to look at the case of a child with CP. Are you treating the language deficits or the pronunciation deficits? If you're treating the pronunciation deficits, you would likely want to code R47.89 other speech disturbances, and then your secondary code would become the code for their particular type of cerebral palsy.
Is there more definition for the other speech disturbances?
There is. If you go to ASHA's, they will actually have descriptions, and we're going to pull up conversions, what the ICD-9 code was, what the ICD-10 code should be. We're going to pull up in a couple of slides exactly what some of these descriptions are. Another instance, if you're treating a child with cerebral palsy and you're treating their pronunciation deficits as well as their language deficits, I believe you could consider coding R47.89, R48.8, because you're treating the pronunciation and the language, and then you would want to report the secondary code, which would be the type of cerebral palsy that they have. You want to match the primary code to what your treatment note would say. Does that make sense? You're sort of with me, sort of not. Sort of, okay. Okay, okay. Now, aphasia codes. And these are those I-69 codes. I-69.020, aphasia following non-traumatic subarachnoid hemorrhage, aphasia following non-traumatic intracerebral hemorrhage. So your aphasias will be in your I-69 code. Yes, ma'am?
I'm just going to go back to, because a lot of kids that we see, it's articulation and it's expressive receptive language, or one or the other or both. So when we put our diagnosis code, are we putting the F80.0 and the F80?
Yes.
Both.
You're putting both. Yes. I'll help you, I promise, at the end. We're going to do some, yeah. Now, ASHA resources, we're going to have frequently asked questions for speech pathologists, frequently asked questions for audiologists. We're going to have mapping tools. We're going to have the most commonly used ICD-10 diagnosis codes. And I will be the first to tell you, the ASHA resources have been my lifeline in this process. I want to start with the mapping tool. Who has seen the mapping tool? Okay, a few hands. This has been phenomenal. ASHA has had this available for a few years. This was viewed so favorably by CMS that CMS asked if they could share ASHA's model with other medical professions during the transition process. Somebody give me an ICD-9 code.
31539.
Okay. It will give me a drop-down menu. I'm going to hit the search button. We're going to make sure I've hit the search button. And it gives me below, it gives me what the description for the ICD-9 code was, and it gives me their possible recommendations for the ICD-10 code. The first one on the list, F80.0, phonological disorder. Functional speech articulation disorder, speech articulation developmental disorder. It's got an excludes 1, meaning you can't pair it with apraxia, because you either have apraxia or you have a functional articulation delay. Excludes 2 tells us it can be paired with F80.4, speech and language disorder resulting from hearing loss. It tells us that it can be paired with the F70 to F79 series. It tells us that it can be paired, to answer your question, with F80.1, which is the expressive language disorder, or with F80.2, the receptive and expressive language disorder. If you are responsible for coding within your practice, this resource should probably become one of your best friends. I have it saved as a bookmark. It is fabulous. Other possible codes, F80.89, other developmental disorders of speech and language, or F80.9, developmental disorder of speech and language, unspecified. That last code would be our code of last resort because it's unspecified. So let's do another one. Give me an ICD-9.
31532.
Okay. So I'm going to hit search. Here we go. The old code, 31532, was mixed receptive expressive language disorder or central auditory processing disorder. Now, we're going to have some recommendations. The F80.2, which is mixed receptive expressive language disorder. But here comes our excludes one. Here comes what you cannot pair F80.2 with. You may not pair F80.2 with central auditory processing disorder, H93.25. You may not pair it with F80.1 because F80.1, expressive language disorder, is a component of F80.2. Another possible, you do have some excludes too. You could potentially pair it with pervasive developmental disorder, which is the F84 series, although ASHA's guidance would be that the R code is more appropriate. You could pair it with selective mutism. You could pair it with developmental disabilities. An alternative code for 31532 would be that H93.25, but only if it's central auditory processing disorder. So this is where that mapping tool is a godsend. It provides you a road map. Y'all want to do another one? Okay, give me another ICD-9. 799.0? Okay. Okay, 799.0 doesn't come up, but I can drop down to any one of those. This one? Okay. Okay, so 799.59 under ICD-9 with other signs and symptoms involving cognition. Their recommended map to ICD-10 is R41.89, other symptoms and signs involving cognitive functions and awareness. And so you can basically go in for any ICD-9 code you may have used, and you can map it to their ICD-10 recommendations. This has been a phenomenal resource. Now, ASHA does have a disclaimer, just so we're clear. It's not comprehensive, although I will say it's been fairly thorough. Read their disclaimer just so you're kind of aware as you go to this site. But this is a site that if you're partly responsible for coding within your organization, I would have it bookmarked. I have it bookmarked, and every time I have a new referral, a new evaluation, I go straight to here. Now, code lists. ASHA has actually created code lists. This is a code list for audiologists, and I believe it's going to actually update to a PDF. And they have an entire PDF, the 2015 ICD-10 diagnosis codes related to hearing and vestibular disorders. This document is even more comprehensive than the ICD mapping tool. And so you can kind of see exactly what it's intended to do. Up to date. And it will go in. And as you can see, 33 pages. Let me get to codes. It will start giving you every single code. So in this case, if you're an audiologist, this is a great resource to have. Like in this particular instance, this page is otitis media H60, and then it will tell you H60.0 is the abscess of external ear, H60.01 is abscess of right external ear, as compared to H60.02, abscess of left external ear, or H60.03, absence of external ear bilaterally. So you will have page after page after page of diagnosis codes specifically for audiologists. I'm going to have to go back here. Likewise, we're going to go to the document for speech-language pathologist. Same general format. It'll give you a table of contents to help you locate things quickly. It will give you resources similar to those that I have given you. And then as you go through, you can look at diagnosis codes, primary and secondary, as they might be related to speech-language pathology. So this is another source for you to use. How am I doing on time? Okay, we're doing good on time. Now, the email that I've referenced and I've said several times, ASHA has a team of individuals dedicated to helping us. The email is simple, reimbursement@asha.org. And my recommendation would be, when in doubt, if you've gone to the ASHA resources, if you're still not sure, when in doubt, send them a quick email. I know that this works because as the state advocate for reimbursement in my state, I frequently get CC'd in on emails from ASHA. We got a question from a provider that seems to be state specific. What can you tell us about this? This is a great resource. This is what, amongst many other things, your ASHA dues pay for. So that's a great resource. Okay, now, I have left us about, actually, I want to show you guys two more things. Escape. Okay. We're going to come down here. We'll start with the ICD-9 to ICD-10. This is available on the ASHA website. It will tell you, it's another form of the ICD-9 to ICD-10 conversion. So if you know that, and this is pretty small, let me see how much I can get this blown up. Essentially what it is doing, it is putting the ICD-9 code directly against the recommended ICD-10 code. So if you find the mapping technique difficult to use, but you're very good with your search functions in an Excel spreadsheet, this is another place where you can access, here was my ICD-9 code, what should my IC-10 code potentially be? So they've provided it to us in more than one way. I'll do a search really quickly. Let's find. And I'm going to find 299.0. Has it taken me there? No. Okay, so it took me 299.0. It took me right to here, 299.0, which was autistic disorder, current or active state. It's recommending F84.0, autistic disorder. It provides the excludes one, Asperger's syndrome, F84.5. So depending upon your comfort level with Excel spreadsheets versus their web function, it's another great resource. They also have that same resource for audiologists. And so if you're an audiologist in the room, you can look at what your ICD-9 code was, and you can look at what your ICD-10 code might be. Yes, ma'am?
The latest DSM doesn't even use it.
Yeah, it doesn't.
It's already obsolete.
In some instances, yes, because ICD-10-11, I believe, is already out and available. So some people have said, how long will we be even on ICD-10? If it's any indication how long we were on ICD-9 in the United States, I doubt ICD-10 is going anywhere anytime soon. But Asperger's is obsolete, so you're not likely to probably get that as a diagnosis code from the pediatrician. You would be more likely to get the autistic disorder, so you would code the autistic disorder. So you do have to know which are the obsolete terms, which are not, and you still have to code appropriately, but hopefully your PCP is giving you autistic disorder, not Asperger's, so you go, I'm going to code autistic disorder. It still all has to make sense. Make sense? So I have left us a solid 20, even 25 minutes. We can do more examples. I am happy to answer you guys' questions. I am here to help you. So now this is your opportunity to pick my brain. If I don't know it, I will show you how I find something when I don't know. Yes, ma'am.
On one of your previous slides, it sort of went by quickly. There was something about an example of a super bill.
A super bill. Okay, let's pull that up.
Actually seeing how this is represented might help me.
Severity. You know what? There's an easier way to find it. Let's just do this. So ASHA super bill. Okay, so we're going to go to model super bill for speech pathology. We're going to get that centered, hopefully. Okay. It's a little awkwardly formatted, but here is a model super bill. So if you're responsible for billing and coding, ASHA recommends you have all of the patient information at the top, their primary diagnosis, speech language pathology. They still have the ICD-9 code, so obviously we need to update that to the ICD-10 code. The secondary, which is the medical diagnosis, again, be sure to use the ICD-10 code. And then they have a list of procedure codes with the appropriate CPT code. And somebody asked me earlier, what do all these CPT codes mean? Here's a spot that you can find them on the ASHA super bill. So you could go to your super bill, you would check, if you were completing the super bill, you would check the procedure codes that you provided, you would have a procedure code, and you would write in your charged amount. Going a little bit further, we get down, you have a total charges in the, I guess that's y'all's, right? And then you have a spot to list what the previous balance is, what today's charges are, the total due by the patient, what the patient paid, whether they provided you cash, credit, or paid using a check, and then you would have the balance. You would also want to sign the super bill. So that would be an example of how you could keep track of all of your procedures, your charges, and your payments. They have one for speech pathologists. They have a super bill for audiologists. So I know that we do not necessarily rely on super bills in our practice, but we do have an alternate system as compared to this super bill. But we are definitely within our practice tracking the dates of service, the procedure codes, our total charge, and our payments, and we are very adept at keeping track of our amount outstanding, our receivables, and what various patients still owe us towards their bills. Whatever system you use, just make sure you have a system. Yes, ma'am?
Every time you talk to a physician on the phone, you use that code?
No, you can't necessarily use a code simply because you've talked to a physician on the phone. If you're going to come this afternoon in the documentation and medical necessity workshop, one of the things we talk about and we'll discuss is every contact you have for a patient should be documented. It can be documented on something as simple as a communication note, date, time, called the physician's office, left a voicemail to speak about this with your signature. Called the parent, recommended to the parent this with your signature. Some of those contacts we have outside of the treatment session are not necessarily billable, but it does, by keeping that communication log, it does demonstrate your collaboration with the family, and big buzzwords we'll hear is family-centered care, with the PCP, the medical home. You are evidencing what you've done above and beyond providing treatment just in that specific section. So if you're not keeping communication logs, it's highly recommended that you do keep communication logs. We have a section in our practice on our treatment note for communication family home program, and we are documenting every session what the conversation was that we had with the family, what our recommendation for the home program was, the feedback the patient's family provided about the home program. We're documenting that every time for every patient encounter. So, other questions? Yes, ma'am.
So I know you were saying for the NOS one.
Uh-huh.
So it's anything that has coding next to it saying unspecified. So any code that we use that says unspecified is considered an NOS?
That's an NOS code, yeah, if it says unspecified. And again, you want to try and avoid them, but there are some instances where it is actually most appropriate to use the NOS. So, others? Yes, ma'am.
Okay, so I'm still a little unclear, but just to give you a quick background, I work in a school, so I have children with CP, autism, Down syndrome.
Okay.
Can you tell me, like, so I use that diagnosis primary first, as long as I have it medically documented?
That's the opposite. So, that's your secondary. If it's medically documented, you're going to use an R code first to code the speech and language deficit. If it's medically indicated. And then your secondary will be the cerebral palsy, the Down syndrome, the autism, if they had an underlying genetic condition.
What number are you talking about?
So, like, that's a good one. Let's pull one of those up. Let me get to ASHA ICD-10. Okay, so we're going to go to a mapping tool. I'm trying to think, an ICD-10 diagnosis code for cerebral palsy. Okay, I'll pull one, no problem, I'll pull one up. And this is what I do when I don't, this is exactly how I do it when I'm not sure. And this is what I think is really beneficial for everybody to see so that you guys can leave and go, I can do this too. So in my case, I'm going to go back to what was my spreadsheet for speech pathology. I should still have that up. Okay, here's my mapping spreadsheet for speech pathology. I'm going to do a quick search. We're going to do a find. And I'm just going to put in what I want to find. Cerebral palsy. Okay, it doesn't like that. So we're going to, oh, I know why. Okay, give me a second here. We're going to edit. We're going to find. Okay, infantile cerebral palsy was 343.9, unspecified. So let's say I go back to my ICD-10 converter, and I don't want to be there. NMSHA ICD-10 converter. We're going to go back to the mapping tool, and now I'm going to type in 343.9. And okay, it'll give me that. Okay, so here we go. The ICD-10 code had been 343.9. The ICD-10 code matching to the same condition would be G80.9 if we were using the unspecified. So you would have the R code as your primary, and in this case, your secondary would be the type of cerebral palsy. Now, I imagine, let me go back to some of the others, 343.3, for example, and let's hope I'm right. Okay, here we go. 343.3 on an ICD-9 code had been monoplegic infantile cerebral palsy. That's going to code over to G80.8, other cerebral palsy. So in this case, for cerebral palsy, it looks like your primary code would be the R series codes. Your secondary code is likely to be in the G series. So that's one way you could help kind of walk yourself down the path to figure out what's the right code.
Okay, so let's just say that the only thing we put down for this particular student is F80.0 and F80.2. That's all we put down. What would happen?
What would happen? And they had cerebral palsy or they didn't?
They did.
In theory, you're undercoding.
Okay.
Right? You're undercoding because all you're saying is they have a developmental articulation delay and they have a developmental language delay. In actuality, they don't have a developmental delay. They have an organic-based need. Here's what could happen. You're undercoding. If you were submitting this to insurance for approval, insurance companies, especially commercial insurance companies, typically exclude coverage for developmental needs or for habilitative needs. If that insurance company has an exclusion and you only code using F80 or F80.2, you may see them deny your request for speech therapy services for your patient because they don't have coverage for that set of codes.
Okay, so in the schools, they only bill Medicaid, they don't bill insurance.
It would depend on your Medicaid payer sources, coverage guidelines. My Medicaid payer source will pay both sets of codes. They'll pay for developmental speech and language needs. They will pay for organic speech and language needs. So if I coded for F80 and F80.2, I would be undercoding and I would not have selected the most specific codes, but I would likely get that approved for services. Now, the audit period, the look-back period on audits, is up to 5 years. If down the road you have selected ICD-10 codes that are incorrect and you are audited, your claims may be subject to recoupment. That can happen in 6 months. That could happen 3 months down the road. That could happen 5 months down the road. If you upcode or overcode and you select R codes instead of selecting F codes, and you are audited, your claims could be subject to recoupment, which is why it's so important to try and drill down to the correct code. Now, we are in a grace period, right? So we have that leeway for that first, we have 11 and a half months left. If you coded it in F instead of coding it in R right now, I think most people would agree you were in the family of codes, so there's likely to be no financial repercussions from a payer source. But this time next year and thereafter, that's when the game changer comes in. So yes, ma'am.
But we are finding, at least in these first few weeks, that our F codes are tending to be denied.
Yeah. F codes are very similar to what the 300 codes once were. They're developmental codes. It goes back to the type of insurance plan, and this is where I nerd out on insurance plans. You have insurance plans. If they are an ACA compliant plan, they must have a provision of coverage for habilitative services and rehabilitative services, meaning whatever they offer for rehabilitative services, let's say it's 30 visits a year, they must also offer for habilitative services. But that is only for plans subject to ACA requirements. We have another group of commercial insurance plans that are considered self-insured plans. Employers are taking on the financial risk associated with the plan administration. They are not subject to the provisions set out in the Affordable Care Act, meaning they can decide if they want to provide coverage for habilitative or developmental needs, or if they only want to provide coverage for organically based speech and language disorders. When you see denials for developmentally based speech and language conditions, there's a good chance it's a self-insured plan, meaning the employer has selected not to provide coverage for developmental-based speech and language delays. When employers are self-insuring, they typically pick a plan administrator like United Healthcare, like Aetna, like Blue Cross Blue Shield, like Cigna, and that insurance company is simply acting as the plan administrator on the employer's behalf. Conversely, if you have a patient that has a plan that's been selected through healthcare.gov and it is an exchange plan, the Affordable Care Act mandates coverage for habilitative and rehabilitative services. Every state has what's called the state plan, and in that state plan there is a provision for the minimum number of services that an insurance company must provide. So if you have a patient who's got a plan that is an exchange-based plan or is subject to ACA compliance, there should be a minimum benefit. If you find they have that plan and there is no minimum benefit for habilitative services, that is when you would want to start asking questions of the insurer. Well, aren't you an exchange-based plan? Aren't you required to have a minimum provision for coverage for habilitative services? But as a general rule of thumb, if it's a self-insured plan, they can choose to exclude coverage for habilitative needs. We have a law in our state that states while they can exclude coverage for habilitative needs, they cannot exclude coverage for children with autism. So if you have coverage for autism, if you have a child with autism, that's a game changer. They must provide coverage whether they are an exchange-based plan or a self-insured plan. We have a state law that says autism is a required benefit. So, other questions?
Did I hear you correctly earlier when you said if you've already been approved on ICD-9s, you can go until you need a reauthorization?
Yes, ma'am, that is correct. If you already have an approval under your ICD-9 codes, you do not need to obtain a new approval using your ICD-10 codes. When the authorization expires and it's time to obtain subsequent prior authorization, you would submit using your ICD-10 codes at that time. So, yes, ma'am.
I work for home care. I'm not the coder, but I just came to try to understand this better. But for home care receiving Medicare and private insurance money, both are in F codes or just
You're,
We use both RNF codes as well.
I'm not as, on Medicare or commercial insurance, both. So you're talking primary, secondary, commercial insurance is primary,
We're not outpatient.
you're not outpatient, okay.
We do home care in the home.
That is one I'm not going to try and answer for you, but I will point you to resources. You could use two things here. Let me get back to the PowerPoint slide. PowerPoint slide, let's get all the way to the end. Okay, so your stamp, who handles Medicare claims, is Julie Borrego, and according to the ASHA website, that is her email on file. So she would be a great starting point for that. Michael is actually y'all's star. So if you had a commercial insurance or a Medicaid question, Michael's a great place to start. And your stars in this case, stamps. Stamps, if you're familiar with them at all, used to be called SMACs. They are great resources. We all have the opportunity to participate in monthly conference calls with ASHA, and basically we flesh out the issues that are impacting our states the most. We begin to determine what the national trends are, because we have what's called MacPac. I don't want to pretend to know the Medicare one. Our state Medicare agent, our states are talking, is the best way to say this. And the state Medicaid agencies are talking with one another. Your local coverage administrators are talking with one another. What starts in one part of the country generally has a trickle-down effect and may end up in other parts of the country. So they're great resources. In their case, if you send them a question and they're not exactly sure, they have a web page that they can go to, and they can send it out to all of their respective stars or all of their respective stamps. I have a provider question. Does anybody have any insight on this? In the case of our Medicaid payer sources, there seem to be a certain number of Medicaid managed care organizations that have a footprint in various parts of the country. We'll frequently see questions like, this Medicaid managed care organization is about to start operating in my state. Does anybody in another state have experience with them? And then if we do, we can all kind of tell them what they might be on the lookout for and what they might expect. So a great place to start for that. So, other questions? Yes, ma'am.
So with ICD-10 had the NEC,
Mm-hmm.
like NOS and NEC.
Mm-hmm.
ICD-10 can have that too. I mean, would you use that NEC like that also classified, or is it because ICD-10 is a little more specific?
I think because ICD-10 is that much more specific, you're not going to see the NEC as much. You may still see the NOS, but I don't know that we're going to see the NEC as much. So, other questions? Okay, thank y'all.